Hey guys, welcome back. I just recorded this whole lecture a minute ago with my microphone turned off, so hopefully third time is a charm here. Alright, so this week of April the 20th, is cardiogenic shock in EMS 160. Cardiogenic shock is fairly straightforward. This is not going to be a long video. We could make it really long, but we're not going to, because we've already covered the majority of the information that we need for managing cardiogenic shock, because, as we'll see in a minute, the basis of cardiogenic shock management is helping to maintain blood pressure until we can get the patient to the most appropriate facility. So the most important thing to know about cardiogenic shock is that we normally can't fix it in the pre-hospital setting. That's something they're going to have to do in the hospital. There are a couple of conditions that we can treat per se, but most of the time we can't do anything about cardiogenic shock. And the reason for that is cardiogenic shock is a heart problem. So the heart muscle itself is not beating adequately. It's not contracting adequately. Maybe that's due to a tachyarrhythmia. Maybe it's due to bradycardia. Maybe it's due to a decrease in ejection fraction due to heart failure. Maybe it's a cardiac tamponade. Maybe it's a pulmonary embolism that has caused the heart not to beat adequately. Whatever and I say beat adequately, I'm meaning pump adequately. So I'll rephrase my terminology there a little bit. But whatever the cause is, this is a heart muscle issue. This is not a vessel problem. This is not a volume problem. This is a heart problem. Important to recognize, because our treatment is going to be a little bit different. This is the same protocol we've looked at before. This is AM5. This is your hypotension/shock protocol for the state of North Carolina. We looked at this with your post-cardiac arrest management a couple of weeks ago. So we're going to pretend like these other types of shock don't exist for right this minute, and we're just going to focus on the left side of the screen where it says cardiogenic. So the first thing that your protocol recommends you do is make sure this patient isn't having a STEMI, or maybe this is a STEMI and that's how we arrived at this protocol. But remember that a STEMI stands for ST segment elevation myocardial infarction. Basically, that means this is a heart attack that I can see on an EKG. Not all heart attacks show up on an EKG. We'll talk more about that next semester, but this is referring to the patient is actively having a heart attack. Why would a patient who's having a heart attack be in cardiogenic shock? Well, when you have a heart attack, the heart muscle is deprived of oxygen, and any other muscle, that's deprived of oxygen, eventually it's going to die. The same thing happens with the heart muscle. So the heart muscle literally starts to die. And if you have muscle fibers that are dead, they obviously can't contract. So you get an area of the heart that is not contracting adequately. And depending on where in the heart that is, it could make a big difference in how well the heart is still able to meet the demands of the body. So consider a STEMI. We can't ever rule it out per se, because again, not all heart attacks show up on an EKG, but we can get an idea. Always have the opinion though, if it walks like a duck and quacks like a duck and waddles like a duck and whatever else like a duck, then it may be a duck. So consider it to be a STEMI if it looks like a STEMI. But let's continue down. All right. And if it is a STEMI, we want to go to our chest pain STEMI protocol, because there are some other things that we want to do there. All right. So continuing on with our cardiogenic shock, the first thing that we want to think about is some type of isotonic crystalloid solution. Your protocol specifically says normal saline. Your textbook says some type of isotonic crystalloid solution. It really doesn't make any difference. The state protocol had to choose something, so they chose saline. And your state protocol and your textbook are going to differ just a little bit as far as the recommended dosage of fluid for the patient in cardiogenic shock. As a general rule, for a patient in shock, your state protocol allows you to use up to 2 liters maximum fluid. We're starting with a 500 ml, and we're going to titrate to a systolic blood pressure of 90 or a MAP of at least 65. Now, if you go back and look in your text, it's going to reference 10 mLs per kg for cardiogenic shock and 20 mLs per kg for other types of shock. The reason for that is, like every other condition we've talked about since the beginning of your program, we always want to think about the underlying cause of the patient's presentation. So if it's cardiogenic shock, is it because of a pulmonary embolism? Is it because of a cardiac tamponade? Is it because of a heart attack? Is it because of this or because of that? Regardless, this is not a vascular problem, and this is not a volume problem if it is isolated cardiogenic shock. Okay, so tons of fluid isn't really going to help this patient a whole lot. It certainly can increase blood pressure to an extent, but it's not going to be super beneficial. So that doesn't mean that I can't give up to 2 liters for a cardiogenic shock patient, but the more volume that's in the bloodstream, the more volume the heart's going to have to move. right? So think of it that way as well. So there are negative effects, potential negative effects to a lot of fluid in a cardiogenic shock patient. Our focus in treating cardiogenic shock should instead be on increasing the strength of contraction, which is inotropy. So we really want to focus on our inotropic agents. We want to stay away from large fluid boluses. We want to stay away from any type of vasopressor agents that are going to increase the heart rate. And we want to stay away from any type of vasopressor agents that are going to squeeze peripheral vasculature. Why is that? Because if we squeeze the vessels or you increase the heart rate, then your blood pressure would go up, right? That's what the body normally does. That's a normal neurohormonal compensatory mechanism. But with cardiogenic shock, remember again, the heart muscle itself is where the problem is, and it's having trouble meeting the demands of the body already. So if I was to squeeze peripheral vasculature, that's going to increase afterload. Remember that afterload is defined as the resistance in which the heart must pump. So if I increase the resistance the heart's having to overcome, then the heart muscle has to work harder. And when the heart muscle has to work harder, it increases the workload of the heart and it increases the oxygen demand of the heart. If we increase those, then we're going to make the heart even less effective in a heart that's not working well, right? So the same principle applies if I increase the heart rate. If I increase the heart rate, the workload goes up, the oxygen demand goes up, cardiac output is going to go down. So we want to stay away from drugs that increase the heart rate, stay away from drugs that squeeze peripheral vasculature. So that leaves us with very few drugs to choose in treating isolated cardiogenic shock. And I'll go ahead and tell you that Onslow County specifically does not have a good drug for treating cardiogenic shock. We use push-dose epi more commonly than anything for this in Onslow County. Push-dose epi is not the best drug for cardiogenic shock. Why? Because epi has a really high affinity for beta receptors, right? Now that's good because we are going to have an increase in inotropy, increase in strength of contraction, but you give somebody epi, their heart rate goes through the roof, right? Now this is a really low dose epi that we're giving. But still, epi is epi, and it's going to increase the heart rate, which is going to increase the workload of the heart. So what's another vasopressor we talked about? Well, we've talked about dopamine, and dopamine is specifically on the protocol here, and that's the only drug that it specifically outlines. And the reason for that, I think we talked about this a couple of weeks ago, but the reason for that is because the state allows each independent system to choose which vasopressor agent they're going to use. So as far as dopamine goes, dopamine we talked about had a low dose, a medial dose, and a high dose. The low dose was your renal dose that dilated renal arteries. Your medial dose was more of an inotropic and chronotropic dose, but specifically more for inotropy. And then your high dose, that was peripheral vasoconstriction. So we could use dopamine. Dopamine would be a better option for treating cardiogenic shock than epinephrine would be, because dopamine is going to affect the heart rate less than epinephrine is going to, and it is going to increase the strength of myocardial contraction. So that's something to think about. What's another vasopressor? We talked about dobutamine, right? Dobutamine, I'm not going to give doses and things. I think that's in your drug cards, but the dose for dobutamine is kind of subjective, and there's not a state standard for that. So that's why we're not talking about an independent dose. But dobutamine is an inotropic agent. It has very minimal effects on the heart rate. It has very minimal effects on afterload, so peripheral vasoconstriction. Dobutamine would be a good choice for independent isolated cardiogenic shock. Probably the worst drug you could give for cardiogenic shock would be something that just squeezes the vessels, and that would be Levophed or norepinephrine. That is not a good drug for treating cardiogenic shock because, again, we squeeze the vessels, it increases afterload, it increases the workload of the heart. That may increase blood pressure temporarily. It is not helping the problem, I assure you. So we really want to focus on medications that increase the strength of myocardial contraction, stay away from medications that squeeze vessels and increase the heart rate, and recognize that this patient is in cardiogenic shock to start with, right? Because we have to transport this patient to the most appropriate facility. And I say the most appropriate facility because not all hospitals are capable of dealing with certain conditions, and cardiac conditions are some hospitals can't take care of heart patients, I guess is what I'm trying to say. For instance, Onslow County doesn't have a cath lab. They do, they don't use it. But they don't use their cath lab, so we have to transport patients either down south to New Hanover or up north, up to Craven. But anywhere that you go, make sure you're familiar with your local protocols and where you need to transport patients. A lot of your local smaller hospitals are not capable of taking care of heart patients. If your patient is extraordinarily unstable, their blood pressure is super low, they're in some some tachyarrhythmia that you can't get them out of, or something like that, they're an unstable patient, don't bypass a closer facility to go to a specialty facility. So we'll use Onslow County for an example. If I'm on Western Boulevard, I'm not going to not go to Onslow to go all the way down south if my patient is super unstable. But follow your local protocol with that. That is the gist of cardiogenic shock. I know that that's really brief. We'll talk about the causes for cardiogenic shock a little bit more next semester. There will be just a little bit of that on your homework, but I don't want to give you all the answers right this second because I do want you to go through and look at some things. But if you do have questions, of course, always, like always, reach out and let me know. Thanks.